So next we have Alex Tran. He did his undergraduate at Concordia University of Wisconsin, and he plans on pursuing a career in retail.
Thank you. All right, so let's get started. So my presentation is on risks of the planet of the vapes. I've been wanting to do this for some time now due to the increased popularity of vaping through different social media outlets. Since the uprise, many online stores and local shops have been opening due to increased use. And as I've been coming across some of these establishments, there are many claims that vaping helps with tobacco cessation and is safer than smoking. Therefore, today I'll be addressing the situation. And at first, I imagine that multi-million-dollar cigarette companies will start to combat the use of electronic cigarettes, but that may not be the case. So kind of going into my learning objectives is to compare and contrast the use of electronic cigarettes to conventional cigarettes, evaluate the available literature relating to the risks and potential benefits of electronic cigarette usage over conventional cigarettes, as well as nicotine replacement therapy. And then lastly, to develop a counseling plan for patients contemplating the use of electronic cigarettes. So a little bit of introduction. For those who don't know who Philip Morris is, he is the founder of Philip Morris International, known for their best-selling product and most recognized Marlboro cigarettes. He is committed to designing a smoke-free future as his New Year's resolution of 2018. They desire to be the first company to take over the demanding market. Therefore, a division in their company, IQOS, which stands for I Quit Ordinary Smoking, designed electronics to heat tobacco in order to release the flavors and nicotine. And it has been launched in key cities in Canada, Czech Republic, and Colombia, to name a few. However, FDA advisory panel decided that Philip Morris could not claim his new smokeless tobacco device is safer than smoking due to no evidence in the reduction in users' disease and mortality risk. So kind of going through the timeline of how electronic cigarettes came to be, we start at the year 2003. The inventor was a pharmacist and who was a smoker who created electronic cigarettes due to his father, who was also a heavy smoker, that passed away from lung cancer. In 2006, electronic cigarettes are introduced to the U.S. by imports. And in 2008, the World Health Organization proclaims that it does not consider electronic cigarettes to be a legitimate smoking cessation aid. In 2009, that's when FDA bans electronic cigarette imports into the U.S. And as a result, CASA forms. CASA is a Consumer Advocates for Smoke-Free Alternative Association. It's an organization made up of both retailers as well as consumers with a mission to ensure the availability of effective, affordable, and reduced harm alternatives to smoking by increasing public awareness and education. In 2010, Smoking Everywhere is also an organization that supports electronic cigarettes. They face the FDA. However, a U.S. Court of Appeals in Washington rules that FDA can now regulate electronic cigarettes under tobacco product unless therapeutic claims are made. In 2011, the first study is published in the American Journal of Preventive Medicine, reporting that electronic cigarettes are a promising tool to help smokers quit. In 2016, that's when FDA starts laying down some regulations on these tobacco products, and they issue regulations on flavoring and marketing as well as sales to minors of newly deemed tobacco products. So that's e-cigarettes as well as e-liquid. And then 2018, as of January 1st, due to the FDA regulation, all newly regulated covered tobacco products must bear the required nicotine addictiveness warning statement on products and advertisements. So is there any difference in safety with vaping? To start, we want to look over what a conventional cigarette is made up of. As you can see, you pretty much know the anatomy of what a cigarette looks like. But however, in the tobacco blend, you can see there's many dangerous compounds, such as ammonia, which is found in cleaning fluid, shellac, which is found in varnish, arsenic, which is known as a deadly poison, benzene, which is found by petroleum fumes, And acetone, as many of y'all know, is a nail polish remover. And then moving forward with electronic cigarettes, the picture above is the electronic cigarettes that will be used in the studies I'll be discussing later. And on the bottom, that image is what a starter kit would look like for anybody who's interested in electronic cigarettes. As you can see by the atomizer, that is where the e-liquid is stored. And then there is also a coil wrapped in cotton. And when that cotton is saturated with e-liquid, the coil will heat up and will disperse the vapor. And the contents of the e-liquid, there's flavoring, nicotine, vegetable glycerin, which is found in low carbohydrate foods for sweetness and moisture. It's also found in many household products. Propylene glycol, which is included in many medications as a way to help your body absorb the medication more efficiently. It's a common ingredient in electronic cigarettes, contributing to the taste and smoothness of the smoke. Do not get this confused as ethylene glycol, which is more dangerous and can be found in antifreeze and other household products. And then kind of moving on to cost analysis, electronic cigarettes versus conventional cigarettes. You're looking at a vaporizer kit costing about $30 to $100. E-liquid would cost $15 to $35 per month. And accessories such as replacement batteries would cost about $20 a month, equating to about approximately $450 to $760 per year. And on the other side, with conventional cigarettes, the Texas state average is $6.69. And if a consumer uses 1 pack per day, that would equate to approximately $2,400 per year. So after kind of comparing and contrasting electronic cigarettes to a real cigarette, is there safety literature involved with vaping? So going into my landmark study, it's in quotations because that's what it was quoted as in Time magazine as well as by the National Health Service. It's nicotine, carcinogen, and toxin exposure in long-term e-cigarette and nicotine replacement users. The methods for the landmark studies is a cross-sectional study that studied exposure biomarkers, including known tobacco-related carcinogens. Inclusion criteria consisted of current smokers only, or former smokers who use electronic cigarettes or nicotine replacement, or they could also be current smokers who are also using electronic cigarettes and nicotine replacement. Exclusion criteria were users of non-nicotine e-liquid, and the characteristics of this study is that there was 181 patients in the study with a mean age of 38 plus or minus 12 years. Cigarettes per day were approximately 13 plus or minus 8, and 60.8% were male. So looking at the primary outcome, it's exposure biomarkers. I've included certain biomarkers of importance measured by urine and blood. The International Agency for Research on Cancer classifies certain compounds by carcinogenicity. For example, carcinogenic compounds such as tobacco nitrosamines would be potent in the lung, and a probable cancer-causing agent like acrylamide would be described as a neurotoxin. And then for statistical analysis, the Sadat correction was used in post-hoc analysis. Bonferroni correction tests are also appropriate because they can be used to run multiple comparisons. However, Sadat correction is more advantageous because it assumes that all tests within the set are independent of each other, resulting in a lower probability of making a type 1 error. In 180 participants, so 36 per group, would provide 90% power to detect between group differences. So looking at the results of the landmark study, there are adjusted biomarker levels by group as a proportion of cigarette-only smoker levels. I did not include the cigarette smoker levels because it can be pretty much well defined within the dual intervention. So whatever I have in the red boxes are what's going to be the correlating p-value towards the rest of the data of the electronic cigarettes in this box. So total nicotine equivalents, you can see that electronic cigarettes did provide a very similar level compared to nicotine replacement and the dual intervention. Comparing electronic cigarettes to other interventions, electronic cigarettes had significantly lower levels of tobacco nitrosamines. And then acrolein and other carcinogenic compounds showed significantly lower levels in the electronic cigarette arm compared to the dual interventions. And then lastly, the other known carcinogens showed significance in lower levels in using electronic cigarettes compared to using the conventional cigarettes. So my conclusion on the strengths of this study is that it did measure 35 biomarker outcomes, and it was done by Cancer Research of the UK. Limitation is that is the statistical analysis. So the statistical analysis showed statistical significance, but may have not shown any clinical significance. Sample size was very small, so it's really hard to diversify it to a larger population. And then study duration, it was 6 months. However, it's a very short time to extrapolate long-term clinical outcomes. And then moving on to my next study, which is a safety study. It's a randomized parallel group study to evaluate the safety profile of electronic vapor product over 12 weeks. For the methods for this study, it's randomized parallel group clinical study evaluating safety lid profile of electronic cigarettes. Inclusion criteria were any smokers or any current smokers using about 5 to 30 cigarettes per day, and they have had to at least smoke for more than a year. Exclusion criteria is any form of nicotine replacement therapy within 14 days. Characteristics of this study is that the sample size is 420, mean age 34 plus or minus 10 years, cigarettes per day. They actually did it in sections, so 11 to 20 was majority of the population at 56.2%, and then 54.9% were male. So the primary outcome of the study was that they were looking at adverse events based on observer and patient self-reporting of symptoms. Safety parameters were also used as descriptive statistics used for adverse events. Those included vital signs, electrocardiogram, lung function test. Statistical analysis used was a repeated measure analysis of covariance used to compare changes from baseline. Patients were randomized into a 3-to-1 ratio of electronic cigarettes to conventional cigarettes, respectively. The exposed population of 300 patients would be necessary in order to have a power of 95% to detect differences in adverse events. And then as you can see from the results, electronic cigarettes have more total adverse events than conventional cigarettes. Headache, sore throat, desire to smoke, cough, increased appetite, nasopharyngitis, and irritability were very common adverse events. And as you can see by the asterisk, with no p-value was recorded for the primary outcome. So kind of in graph form, x-axis being the study week, and y-axis being frequency of adverse events. Gray line is conventional cigarettes, and red line is electronic cigarettes. You can see that most adverse events occur in the first week when being introduced to electronic cigarette product and plateau over the following weeks. Overall, there are no clinically significant findings or changes from baseline for any of the clinical laboratory evaluation, vital signs, lung function tests, or electrocardiogram parameters during the course of the study. So I did not include that in my presentation. So strengths is that the study focused more on the clinical outcomes from their safety parameters. Limitation, there's multiple sample sizes to reduce false product-related effect. Longer studies with a greater number of patients would be required. Statistical analysis, as I said before, no significance or p-value was shown for the adverse events, which was their primary outcome. Nicotine withdrawal may have been contributed to adverse events, as nicotine equivalents that they measured were lower compared to the baseline for the electronic cigarette arm. So they weren't getting enough nicotine during that first week, which resulted in the increase in adverse events during that time. It was also funded by the manufacturer of the electronic cigarette. And then other pertinent studies that I've come across, going to the first one in 2007, it was electronic cigarette with or without nicotine in the e-liquid. and it was shown that nicotine was the main factor that attributed to the acute sympathomimetic effects of electronic cigarettes and not the constituents of the e-liquid. And then going into my second study, they did cardiovascular and pulmonary function endpoints comparing electronic cigarettes to conventional cigarettes, and that showed statistical significance to reduction in systolic blood pressure as well as increased FEV1 from baseline. And then kind of going into my last study where 20 current smokers were switched over to electronic cigarettes for 2 weeks, and it also showed that equal nicotine equivalents from baseline and a decrease in carcinogenic markers in 1 week with a 45% abstinence rate from conventional cigarettes. So after gathering the study, what is your response to a patient wanting to quit using tobacco? So by the 2008 clinical practice guidelines for treating tobacco use independence, as a pharmacist, you need to assess the patient's willingness to quit and then begin effective counseling interventions. Those would include basic information on short-term and long-term effects of smoking cessation, recognize dangerous situations such as the increased risk of COPD and hospitalizations due to infections, and then encourage the patient in their quit attempt. And then next, you'd want to develop an appropriate tobacco cessation regimen for those who are ready. So refer the patient to an appropriate organization that offers counseling. That can be us in pharmacy clinics. And then we would provide practical counseling, which includes problem-solving skills training, intra-treatment, social support. And then you'd move on to clinical use of pharmacotherapies in combination with counseling. So that would be beginning them on gums, lozenges for nicotine cravings, as well as patches. And then you'd also want to incorporate effective non-traditional adjunct therapies such as meditation, yoga, and hypnosis. But however, if a patient still wants to pursue utilizing electronic cigarettes as their smoking cessation tool, as a pharmacist, we need to educate them. So we would need to counsel the patient on the safety outcomes from available literature. Yes, it may reduce chances of carcinogenic effects. However, there are increased adverse events. Electronic cigarettes are the leading cause of nicotine poisoning. Here I've noted the adult lethal dose of nicotine, which is less than 60 milligrams or 0.8 milligrams per kilogram. Symptoms of nicotine poisoning would include tachycardia, cold sweats, blurred vision, dizziness, and headache. The plan for the electronic cigarette users is to use at their own risk, keep out of reach of children, because it is in liquid form. It can be ingested or absorbed through skin. And then always read the label on the e-liquid vial to look for the ingredients. And then further studies, the impact on cardiovascular function in smokers making a quit attempt using e-cigarettes compared with smokers making a quit attempt with prescription nicotine replacement therapy. This is a pretty big trial that's going on right now. It's an intervention for 3 months. It's behavioral change support with nicotine inclusive and nicotine-free electronic cigarettes, and that will be actively compared to nicotine replacement therapy. And I'd just like to acknowledge Dr. Mack for helping me with my grand rounds, and then I'll be taking your questions. Travis.
So you didn't really talk about it, and I don't know what it is, so maybe you do, but I've heard something called popcorn lung being associated with vaping. So do you know what popcorn lung is and how significant of a risk is it if you vape, and how debilitating can it be?
Okay. So your question is about information about popcorn lung. So popcorn lung is the inhalation of diacetyl, which is buttery flavored chemical. The real name is bronchiolitis obliterans. It's scarring of the bronchioles, thickening and narrowing of the airways. Unfortunately, there are no mentions of popcorn lung within the studies that I have presented today. I also am doing rotation in the ED at BSA, and I've asked, and no one has ever seen this. It's very rare. This came out because of the 1960s when manufacturer workers were in popcorn factories, pretty much. What's that?
Did you pay him?
No, because it's a very big thing right now, because a lot of people are trying to associate that with popcorn lung. However, I haven't seen it, and I knew it was going to be a question, so. Because it's spread throughout the social media about it, so.
I swear he didn't tell me to ask that.
Let's see if he gets this next one.
Yes.
So in your safety study, you talked about adverse events. Like, what were the ones that the e-cigarettes experienced? Because you didn't show any. Like, what was the actual events that they experienced?
Can you say that one more time?
Like in your safety study, those adverse events that occurred.
Yes.
What were they?
I kind of mentioned it, but the most common adverse events, I've actually put it, again, most of them were headaches, as you can see here. And I think it was pretty much due to the nicotine withdrawal because they weren't being provided enough nicotine from the electronic cigarettes. And as you can see from the graph, that it did drop down after the first week.
Can you go back to that slide you were just on?
Yeah.
So it looks like the electronic cigarette group has quite a bit higher percentage of desire to smoke.
Mm-hmm.
So do you think that could be a limitation of it being an effective device to quit smoking?
The thing is with that is it's hard to gauge I believe for the researchers, it's hard to gauge how much nicotine they're actually getting because like they split in those numbers where I said it was about 11 to 20 were majority of them. So it's really hard to gauge how much nicotine they'll actually need. So after that first week, after that rise, because it rose about 135%, once it reduced down, they were able to get how much nicotine they're actually needing.
Did anyone in the study say anything about, sorry, I'll sit up, like the act of smoking, the act of lighting a cigarette and versus just puffing on a e-cig? Do you think that has something to do with the difference in desire to smoke? I mean, did they talk about that? Certain people say that I know who.
That was just like more like a habit, like the
act of doing it versus what is it, like a routine or like a habit of just actually lighting the cigarette versus puffing on something.
Did they like mention anything as in like the oral fixation of doing it?
Yeah. Like an actual thing or.
They did not, because what they used were different scales for subjective effects. They actually used just a withdrawal scale, and that just has a scale of your desire to smoke and then how you're feeling.
So they did attribute it to the not enough nicotine versus the actual.
Say that one more time?
They attributed it to not getting enough nicotine.
Yes.
Versus the actual act.
Yes.
So I don't know anything about electronic cigarettes really. So if you're wanting to quit, like, is there a way to step down? You know how like there's gum, you can patches, you can step down. So can you pour less into it and get less nicotine? I don't know.
So like going to a local vape shop, they do come in different strengths. So like 3% would be 3 milligrams per milliliter. Average cigarette would be about 12 milligrams. So depending on how long how active you are with that electronic cigarette, it depends on what level you can get. So what cigarette smokers, they say they usually buy about 18%, so 18 milligrams per milligram. So it will be reduced down.
Did they mention anywhere which strength they used on these studies?
So did they mention any strengths they used in the study? They started at 2.1%. milligrams per milliliter.
I have one more. It's a
Yeah.
good presentation. I love the
All right.
So, how do you feel? Do you think that vaping is going to be an effective quit method or a tool for older populations? Like like some old man who smoked Marlboro Red his whole life, is he going to want to like switch to vaping like Tutti Frutti or watermelon or whatever? Like, do you think it will not appeal to older populations, or do you think that they could get into it?
Do you think they'll appeal to it? It all depends. There's a lot of confounding variables. I would say it's up to them. Through personal experience, I do have family friends that actually use electronic cigarettes. They say it's not that good compared to the real thing. However, due to health conditions, they want to switch over and still kind of get that oral fixation going and whatnot, and the nicotine delivery.
Alex, my question is just on that first study where they looked at the biomarkers. Are there any studies showing a causal relationship between those individual biomarkers and things like lung cancer, COPD, cardiovascular disease, all the things we think about being the bad long-term effects of cigarette smoking?
So your question is the compounds, are there any causality? I try to look at that because looking at these, I don't know if they're clinically significant with these levels. Because you could say they're statistically significant. However, I said they might not be clinical significant because I try to look these up to see what the upper limit is for some of these compounds, such as the tobacco nitrosamines. Since it is group 1 from the IARC. However, they do say that there is a causality, but I do not know how much. I did also do more research into it. The FDA also has regulations on tobacco products, so you can't go over a certain amount of each type of compound. And they have regulations on that for the cigarette manufacturers.
One last question. Did any of these studies happen to look at whether or not e-cigarette users are more likely to send snaps to their friends blowing smoke rings?
Okay, so I smoked a cigarette one time and I threw up. And I was like 9 years old. And I found one that my dad had left around or whatever. And so I've never smoked a cigarette since then. And so I guess I don't understand, like, what do these things do in the cigarette why are they needed in a cigarette? Like, what are these things that all these cancers, why are they needed in cigarettes? Why can't we just take that stuff out of the cigarettes?
Just because it's a tobacco blend, for pretty much how they manufactured it, for the taste, depending on the consumer.
Okay, so it's not, these are not things that are added in the process?
I don't believe so. Well, most of these, because I kind of looked at some of these compounds, what happens is these are broken down into these parent compounds due to having like acrolein is also found in if you burn fat from just cooking. So it's whenever you're burning something that compound will be exposed.
Okay. So these things are not necessarily related to the enjoyment of the cigarette?
They're not related to the enjoyment?
I don't know how to ask this, but...
Like if you took acrolein out,
yeah,
would the cigarette be ruined?
Like
yeah,
it's
or
just
are these
like
things, is this just in
smoke
tobacco plants?
Yes. Well, I'm not 100% sure, but the thing is, again, these are just what's being lit up.
As it's burning, these things are made?
Yeah.
I think
Okay.
it's like lights, menthol, all the different kinds. Maybe they add certain
Okay.
things. That's what I would think.
I guess I'm just ignorant in the whole realm of why
Or like
these things
slower
are made.
burning cigarette, you know.
So it has to do with the burning of the stuff and all that. Okay, all right. I'll just, I'm too ignorant to ask a legitimate question about all that. So let's move on to the next thing. As far as you gave I think it's slide 21, there's like 3 trials that are Additional trials?
Yes.
Can you give me the pros and cons of the second trial using FEV1 as a marker there? How might that be positive and negative to use that as one of your outcomes?
How can it be a positive and negative? A positive, it kind of tells you a little bit about your lung function. However, kind of like going through spirometry, you'd need like the FEV1 over FEC or something.
Okay. I'm assuming it was a pretty short-term study,
Yes.
so we probably wouldn't be like diagnosing COPD from it. But you got healthy people, right?
Yes.
Okay. And so what evidence is there that short-term smoke exposure impacts FEV1?
Can you say that one more time?
What evidence is there that short-term smoke exposure impacts FEV1?
That short-term smoking may not impact it at all, maybe.
Okay.
When I looked at the results for the FEV1 for that one, it's not that big. Even though I kind of said it increases FEV1 from baseline with that significance, you're talking about not that much, because within that 1 second of air.
So less clinical significance, maybe. And the last question I had is related to the adverse events that you were talking about. And as pharmacists, I think your words were, we need to know how to counsel our people on this, right, when they are thinking about using electronic cigarettes. So what specific target audience would you have in your patient population to say, this group of people really, we need to be concerned about them using electronic cigarettes? Would that be your heart failure patients or your dementia patients? Or what group of people would you have to say, these people we don't need to use e-Cs in?
So that they should avoid it?
Yeah.
Through what I've researched, it should be teenagers, mostly. I've looked at the FDA statistics from 2016, which showed about 2.2 million U.S. Teenagers from middle school to high school have actually been using electronic cigarettes. And they did a survey on them that 81% of them just find the flavoring is what's most appealing them to using it. So.
Are there any disease states, not necessarily age groups, but disease states that are more at risk from using them?
More risk, it would be the COPD and asthma patients, I'd say.
Any other questions?
I just want to know what other slides he's got hidden away.
Yeah.
Wait, what?
I just want to know what other slides you got hidden away. You were
Oh.
at 31, slide 31, and you ended on 28, so I want to know what else you're hiding.
Oh, I was just, some trap cards, but just like, if they were going to ask like the quit rates of the other nicotine replacement therapies, and then just more subjective effects. And then if they said if the scales were valid, I would just say if the withdrawal scale was valid or not. That's it.
It's